To start the presentation, do you want to present yourself and also your hospital and a little bit about your team and about your work? What are you doing and these kind of things?
Okay.
So if you wanted to start, so you are free to start.
Okay. Good afternoon, everybody. This is my real pleasure to accept this invitation, this kind invitation about surgery Valle d'Ochoa. I am Andrea Poggetti, and I am an end surgeon, and I work in Florence, in Italy, in a hub hospital, in a hub hand and microsurgery reimplantation center. And this is my pleasure to speak about the Venous flap in this afternoon. So in our daily activities, the surgeon in general love the predictivity. In case like this, everybody knows predictable with a precise anatomy and precise manner to rise the flap could be a great opportunity for us. And we know the behavior of our flap. This is the immediate post-op control. And we used to check the normal, the traditional flap. We use this kind of technology. And it's important because we arrive to understand if we have any problem about the flap. If we have any problem, if we have a problem about congestion, we are able to check clinically, but also we are able to check using this kind of machine that is really, really useful. We are able to come back in the OR. We review, we perform again the anastomosis, and the vitality and the health of the flap rise. But when you spoke about the venous flap, it's important to forget the concept, because the venous flap are anti-physiological flap. So it's important to back to the start and start again. The venous flap is very fascinating flaps because there are a lot of advantages. It's possible to use a multi-donor site, usually on the palmar side of the forearm, but I'll describe a flap raised from the foot, no sacrifice a major arterial axis. It's a very easy and fast dissection because your dissection starts from superficial layer. You can use a long vascular pedicle. The skin is thin and pliable, and it's quite versatile shape, and it's possible to customize it and to rise with a composite other tissue like a nerve or tendons. But I've described a lot of these advantages. And in our mind, it's not possible to have a precise predictable of the outcome of the flap. So the literature will show us a lot of papers that spoke about the experimental study, cadaveric study, and clinical studies. The major part of this effort come from the 80 and run to the 19 and arrive to 20 to describe this kind of flaps and the physiology of these flaps. So I try to analyze this kind of literature, and I found 5 important keystones that I show in this graphic. The first one is the paper published by Tate that describe a flap that could be raised only on the vein system. He described 2 types of vein flaps. The first one is a type 1, is a flap in which the inflow and the outflow arrive only from the same vein. This is a disaster because the rate of survival is really, really poor. The second one is possible to use the vein to create an inflow, the other part of the flap create the outflow. In this case, type 2, these flaps are more consistent and the rate of survival rise a little bit. And the third one is the arteriovenous flaps, in which it's possible to connect the artery and to use the flap as a flow-through flaps. So the important message that this author sent us is that the venous flap can survive as a free flap, despite the absence of conventional artery inflow. Second important step about the literature is the work about Nakayama, sorry. He studied abdominal flap of the rat, and he raised the flap and leave the drainage only on the proximal part of the flap. And he analyzed, obviously, this kind of flap has the problem of the failure of the distal part of the skin. And he put anastomosis, he realized as arteriovenous anastomosis using the epigastric vein and the femoral artery of the rat. In the rat, with the anastomosis, with the arteriovenous anastomosis, the distal part of the flap can't go to the death, okay, remain healthy. This study is really important because create the message that arteriovenous anastomosis can be help the health of the flap, and the arterial blood is forced against the physiological inflow of the flap, but spoke about to try to avoid to create a short circuit, so the arteriovenous fistula near to the arteriovenous anastomosis, and underline that there is kind of anastomosis realize an anti-physiological circulation. So another key point about this kind of paper is to increase the survival rate of the flap should be rise after a delay. Third very important paper then spoke about the venous flap is this one about this Austrian colleague, Mosheimer, show us that if you they realized this paper using a fresh cadaver venous flap, if the flow is realized using the anterograde way in the right side of the picture, the blow go into the flap, but is unable to arrive to in the peripheral part of the flap. In hand, if you use the retrograde way to push inside, the inflow is really clear how the circulation increase on the peripheral part of the flap. This is really, really important concept because the retrograde way means to try to put the blood against the vein valves and to put and to force the blood from the fascial vein directly to subpapillar venous plexus. This is if you put the same concept with anterograde way, and this is what happens if you put the circulation against the valves. You open the very peripheral short communication between the artery and the veins, and you increase the vascularization of the flap. So how to improve the peripheral perfusion with a retrograde arterial inflow against valves? This concept is really, really important, but have a little bit tricky, because in the proximal part of the flap, the vascularization is quite good, but in the distal part of the flap, the vascularization is a little bit less. Why? Because the circulation inside the flap arrive to arteriovenous shunt, the short communication between the artery system and the venous system. And you realize a very well-perfused part of the flap, and at the same time, as more not so good perfusion of the other part of the flap. So this is what can happen. So the blood flow could be directly from afferental artery directly and bypassing the peripheral tissue, causing the ischemia of the distal part of the flap, but at the same time create a congestion of the proximal part of the flap. So in base of this information, it's important to try to read the superficial part of the patient, the superficial, the skin of the patient, and to analyze topographically the vein distribution. Because in this manner, it's possible to create something that could be the healthy of the flaps. As shown by Yu Telin, is an author that stressed the concept about the simulated valves. So to create with a liga loop a gradient of flap of a gradient of blood from the inflow to the outflow, and he recognized a very specific pattern of vein distribution inside the flaps. So the vein distribution is like this, could be like a E. This is a very easy, a flap with only one vein, and it's important in this case to maintain the healthy of the flap to close the middle part of the vessel. In this manner, it's possible to force the inflow directly into the superficial part of the flap and increase the different gradient of pressure from inflow and outflow. This kind of flap could be used as a flow-through flaps. The other very common pattern is the H pattern. It's important to close the communication in the middle between the two parallel system of veins. The parallel veins could be another type of topographic distribution of the vein. In this way, it's important to close the final part of the inflow vein and the proximal part to the outflow vein. I'll describe other two types, the lambda, like this, and the pattern like Y. So this paper shows us that the hemodynamic validation of peripheral perfusion increase the health of our flaps. It could be predictable our flap rather in the past. So, but in this case of paper, the authors use the anterograde inflow. At the end, the final paper that summarize the concept that I spoke, because Thomas Giesen, a very kind of friend, used the old concept that I show you and used the retrograde way to inflow into the flap using a close communication of the arterio-venous fistula. So in this way, he demonstrated that with the Indocyanina green and monitoring the flap directly during the operative time in just to increase the health of the flaps. So this is an important, he described an important roadmap to raise this flap because it's really important to eliminate the arteriovenous shunt inside the flap. And he described how the flow from the vein start and go to the peripheral part on the flaps, and from the peripheral part shunt from venular system to artery system, and to go to the outflow system. So now you have probably you have the complete knowledge about the flaps, and now you are able to plan your flap to cover the digit and cover your hands. So this is the 8 point. Then you can use as tip and tricks, because the flaps you can be used as a free flaps. It's important to do as a retrograde. It's important to have in mind to shunt restricted is mandatory. It's important to take in mind the number of afferent vein and the number of venous plexus inside the flap. It's important to choose the diameter of the vein, of course. The recipient bed and the monitoring could be quite easy, rather the best. The indication in emergency, defect in the hand and fingers with bone, tendon, vessel, and nerves infections, or in delay in post-traumatic skin contracture, especially for the first web space, or pulp reconstruction, because it's possible to raise the flap with a nerve inside. This is our clinical cases that we perform in our institution. And I show us only one case before I leave the floor to my colleague. This is a very young guys with a sequelae or childhood born injuries, with a multiple history of finger amputation and skin graft to cover the defect, with the grow arrest, especially of the dump, and the very important web contractures. So in this way, 25 degrees of contracted defect wet space is a clear indication to correct this kind of closure of the first web space. And in case of first web-based contracture, we need to analyze that it could be necessary to treat a very important cutaneous major defect, because with this kind of inability, it's impossible to use the dump correctly. So in this case, could be treat the patient with splinting, K-wires between the first and second metacarpal to open the first web. Using external fixation could be an option. Skin graft, zeta palsy, local flaps, regional flaps, free flaps, intrinsic muscle release, or trapeziectomy. So Paco Pignal show us that there are 3 clear periods of first web contractures. Our case is a fixed, is independent on the severity. And in this case, the major problem is a cutaneous problem. So this is the X-ray of the patient, and this is the step that you need to rise. So another important thing to take in mind is that when you open the first web space, you realize a pyramidal shape. It's not so simple to cover this kind of defect. So come back to other patient, which is the option. Posterior interosseous artery flaps could be an option. Reverse radial forearm flap, the same. Free lateral flap could be a good option. Growing flap, why not? Or others. Obviously, we choose to use a Venous flap. In this case, we treat before, and we try to open the west space of the long finger, and we plan on the proximal part of the forearm in order to match the vein with the dorsal branch of radial artery. And we draw this kind of flap with an H shape. We perform the rising and we close the communication between the two systems. We open the first west space and we put inside the flap. It's clear that if you plan, if you realize your flap in this manner with respect the principle that I showed before, the same is possible to use the same manner to check the flap that ordinary flaps. We use the skin, then we removed from the first web as a skin graft for the other fingers, and this is the results after a short follow-up. This is the results after 6 months of follow-up with a very, very pliable skin, with a big opening of the first web. And this is the forearm with a very small damage. This is my conclusion, very short. The arthritis retrograde free venous flap are useful for complex reconstruction of the hands and the extremities. Thank you. Now I leave the floor to my colleague, Olimpia. Thank you.
Hi, good morning to everybody. I'm a colleague of Dr. Andrea Poggetti. I work in Florence with him, and I would like to show you some clinical cases of free venous flap used for fingertip reconstruction. So I try to share the video, the screen.
So Andrea, in this case for the first web, it was only one artery, the flow it was inside and only one vein coming back.
Yeah, yeah, only one, because it's not too big.
Okay, okay. I am always reading about these kind of flaps, but at the end, I always choose a normal one. Or, for example, in this case, I suppose that I choose a PIA flap because I am scared about that. But after these tips, maybe I am a little bit more confident
I
to
hope so.
choose it. Yeah, yeah.
But I think that in general, if the venous flap fail, it's not so important. You can do the PIA flap or the other options.
Yeah, yeah, it's true. It's true that at the end, so you are not doing a lot of damage. Um, so yeah, it's true, and also it's very attractive because it's very thin, very pliable. So the quality of the skin it's very good. But I am always scared about the congestion.
Yeah. But now I think that after the cases presented by Olimpia, you could be more confident.
Okay, thank you. Let's go.
Okay, so are you able to see my screen? Everybody?
Yeah, yeah, we could see the presentation.
So now we will see several clinical cases, and we try to focus on the strength and pitfalls, focusing on the design of the flap. So this is a young male of 16 years old who made a bike accident, suffering a soft tissue loss of the forefinger in his dominant right hand. So if we would like to make an injury assessment, we can see that there is a fingertip loss with bone exposure and with flexor tendon profundis insertion exposure. However, the tendon works very well and the DIP joint was functional. So we have to concentrate on the soft tissue loss. So we thought about the free venous flap. So first of all, we have to design the flap in a manner that is that has a shape similar to the recipient, but we have to make a dimension that is bigger. So the soft tissue loss was more or less 3 per 2 centimeters. So we design a flap of 4 per 3 centimeter, because after we will see that the flap will contract too much. So I have a wishing list to create the architecture of my flap. So I would like to create the flap in a retrograde manner. I want to do a shunt restriction. I would like to include as many vessels as possible in order to include as many subdermal venous plexus as possible, as Andrea told you in the presentation before. And we will see all reconstruction for long finger and for fingertip. So we would like to have the artery and the vein by the same side, because we will perform a proximal anastomosis both in the artery, in the digital artery, and in the digital vein.
Olimpia.
Yeah.
One question, and in your wish list, do you want to have also a nerve to improve the sensibility of the top of the finger?
Thank you for the question, because it's an interesting point of the free venous flap. For the moment, we never included a nerve. Only one time in our clinical cases. For all other cases, we never included a nerve. But at distance, there is somewhat of sensibility. So Weber test, it's not excellent. So it's not like 4 millimeter at Weber test, but we arrive at 8 more or less millimeter. So it's quite good also without taking a nerve. But this is our interpretation because we have already to demonstrate it.
Okay.
So how to go to the next slide. Sorry, 1 minute. Okay, now you can see because it's a little bit strange. I don't know. Okay, so we designed the flap.
Olympia, now we can see the presentation.
Yeah, I don't know why.
Try to share again.
Yeah, I try to share again. Okay. Okay. Now it's okay. The problem is to go to the next slide. I try again. Now it's okay. So we designed the flap with the H pattern. So as you can see, we have a vein who was arterialized and the vein which remains like vein for the venous drainage. And we have two shunt between the new artery system and the vein. So the part where we make the anastomosis, we have to check well the direction, so we made it retrograde. Then we put a restriction to our shunt, so we close the terminal part of the new artery and the vein, and we close also the connection between artery and vein, so that the artery push all the blood against pressure, against valve, more pressure, and so blood is perfuse all the subdermal plexus. So as you can see here, when you make your design on the skin, you can understand where the shunt are located, and when you open, there is not exactly the same of the design of the skin, but it's really similar, and the shunt are there. So the message is to study very, very well your skin before so make a well design, a well planning before to do surgery, because it can guide you during surgery. So we know already where the shunt are. And
so this is before the tourniquet. Some tips or some tricks to do it.
Yeah, I show after that the tricks is to close the shunt before connecting the flap from the recipient side, and we make our dissection under tourniquet, but the tourniquet is running without only
without expression.
Yeah, exactly. Yeah. I don't know how to know. Sorry.
But the idea is to design the flap before the tourniquet.
Yeah, absolutely. Before tourniquet, you put your arm downstaging only with a little compression, like in venous blood sample. Okay. In the same position, so that your superficial vein tree is clearly visible. So it could be more simple in very, very white people like me, that we make never get the sun. It's quite tricky in dark people, but you can also feel your vein on the finger. so feel the prominence of the vein. It's more difficult to check and understand the shunt between the main vessel of our design. So I need to make another time like this, because I'm very sorry, but I have a problem. I don't know why. To go forward. Okay. So the other thing is to include the more venous that you can. So in our design, we calculate another vein more than the artery and the vein, the principal afferents and deferents of the flap. This is useful to include more subdermal plexus, and so to have more chance to have a good vascularization of our flap. So as I said before, calculate your flap bigger than the defect because the restriction is quite too much. And this is the immediately postoperative results. So as you can see, the flap was 1 centimeter bigger, but it fits very well, very nice. And this is...
I have a question. So the artery, it was volar, and the vein, it was dorsal?
Yes, absolutely. We take the radial digital artery to make the vein arterialized, and we use the dorsal radial vein to anastomose the efferents, the vein efferents.
Okay. And in this case, it was 2 veins or 1 vein?
No, only 1 vein as efferents.
Okay.
Because it's for finger, we saw that the flap that we need is generally little, and 1 vein is sufficient. In literature, we found that it's useful, the second vein, for venous drainage. If we make a very big flap, about 10 centimeter per 10, or really, really big, not in this case that are really small. And so this is the results at 1 month. These guys had a little bit personal problem of healing, as you can see, because he's a really young guy that at 1 month it's not normal that you have also in the wrist some part of the scar that wasn't healed. So when I admit a person, I can go forward. That's the problem. I now understand. I don't know why.
I am admitting the people. Don't worry about that.
Okay, so I'm really, really sorry.
No, don't worry. Why do you think that this is superior to a hemipulp, for example?
I think it's easier. So for very young surgeon, I think it's easier to take a venous pre-flap more than an hemipulp.
It's almost the same. So it's true that it's in one field, but you have an artery, you have a long vein, and also almost for fingers, I think that the glabrous skin of the foot, it's more similar to a finger. I think this. So it's my opinion. Obviously, it's very attractive idea, but I don't know if it's for fingers. It will be my first option.
I think that in the case of hemiopulp, it's quite easy because you know where are the artery and where are the veins. So if you try to realize this kind of flap, you need to plan the flap. You need to choose where your vein, afferent vein, you need to be draw and efferent vein where are, and it's a little bit difficult in the part of planning. This is my opinion.
And also Andrea, in this case, so this is not easy, because at the end you are doing very short anastomosis in the dorsum of the finger. So you are not going to the dorsum of the hand, so you are in the dorsum of the finger. So this is a very good surgical technique. So I think that I don't know. For almost in this
Another,
case, I don't think that it's superior to a MIPOP.
probably there is not a winner. So
Yeah.
two different way to obtain the same results. Another thing is that you can choose the diameter of the vein because you prepare the recipient bed. You see the diameter of the vein and you can plan and harvest the vein in the proper diameter.
Yeah.
I'm sorry, Olympia.
No, no problem. So at the end, at 3 months, so a real short follow-up, the function was normal, and it had also a pretty good results. So another clinical case, he is a man of 28 years old. He made a motorbike chain amputation of his thumb of the dominant right hand. So it was an oblique amputation with loss of length of the thumb and with flexor tendon exposure, and the radial part of the distal phalanx exposed, but we have an insertion of the flexor pollicis longus valid with a good function of the interphalangeal joint. So we decided to try the free flap. And also in this case, we designed the flap bigger, about 5.4 centimeter, and we respect all the wishing lists. So we design it with a retrograde flow, with shunt restriction, including another vein without anastomosis, and we choose an arterial vein by the same side of the flap. This was the shape, another type in NH pattern. This is the shunt that you can see in the image on the right, and the problem was to it's impossible to go.
It's always with someone new at the.
Yeah, but I don't push admit, but it's the same. I'm so sorry.
Don't worry, I don't know why it's working in this way.
I don't know why. So
We have time.
The problem could be the tropical weather in Italy.
Yeah, maybe.
So,
but we are fine. We are having a good time. So
okay. So in this case, I show you a little mistake that I made, because before to disconnect the flap from the recipient side, the shunt was visible really well, but I don't close the shunt before to disconnect, but after, and so I had to search for the little vein, and so the results was that I create a little injury to the subdermal plexus of the central area, which correspond to the shunt, where I search for the little vein, because the shunt are very, very thin. It's not like our main vessels, so it's difficult to find it after the connecting the flap. So the suggestion is to close the shunt before the connecting the flap, so when the blood is inside and we can see it very well.
And this is only one. What's the normal? So only find one or two shunts, or more than than that?
That's really, really high variability because it's dependent on person, and it's depend also on where you take your flap, because when you are very distal in the wrist, there are a great reticulus with many connection, and when you go more proximal, there are a little bit less connection between the big veins. So the focus is to design it very well before surgery, and so to find your shunt before surgery and to check it inside during the procedure, but before the connecting. So in this case, we found only this single shunt between artery and vein, and then it's important also to close the terminal part of the artery and the vein. That's also important. It's like a shunt if we don't close it.
Olimpia, do you know what? I'm not going to accept nobody more. And if they wanted to see the speech, so they should go to YouTube. So because if every person who is entering, you have the
Okay, we try to go on. So I continue. Okay. No, because there is another admission.
But even without accepting him?
Yes, even without. I don't know why. Now, is it okay? No. Never.
If you should choose, it's better to choose distal forearm or proximal forearm?
A distal forearm. I
will try to continue.
Andrea disappeared.
Yeah, the distal forearm probably is quite good in order to obtain very small vessel. But it's a little bit tricky because the skin, it's really attached to the distal fascia of the forearm. In the proximal forearm, it's more pliable, but the veins are quite big.
Did you try from this part of the...
Never. That could be an option.
This is very aesthetic. So sometimes...
Yeah, but probably the problem of this portion is that if you use the tourniquet, it's a little bit difficult because you have a tourniquet on, and there is a very small area here to rest the flap.
Yeah. I think that Olimpia is here.
I can hear you, Olimpia.
Yes, I'm here. Try again another time.
Where did you go?
I really don't know. So I try to not to put in presentation mode. Try with in this way, okay? If you are agree, you are able to see the screen. Okay, so also in this case, we take this vein as a supranumerary vein, and so we made the artery with the radial digital artery of the thumb and the vein with the dorsal radial vein of the thumb, and at the end we had a little bit of sufferance, as you can see in the video. I think because of my mistake, but at 15 days it was quite nice, and this is at 1 month. Right. So at 1 month he used his hand very well, and he is our guys at 3 months. post-operatively that he is able to write, to send a goodbye to us, and he is very happy of his thumb. Also, the skin is really pliable and soft, and the shape of the fingertip of the thumb was repristinate. So we see another case. He is a male of 52 years old and suffered a trauma with brushing machine at the third finger of the non-dominant hand. He had an extensor tendon who was continuous, but with bone exposure and tendon exposure. So we designed the flap. We planned our flap, but also in this case, we took a flap not following all the wishing list. So we made a retrograde flow, but we didn't make a good shunt restriction because of the very short of the cross of the Y shape of this flap. So the problem was that we were able to close only this shunt there, but not this, because it was too near to the anastomosis. And so we didn't include other vessels in the design. There was only a little vessel here, but not continue for all the flap. And we were able to put the artery and the vein by the same side. So as you can see here, for our design, the proximal part of the flap had a sufferance with venous congestion, and at the end, the distal part, who hadn't had this sufferance, was very nice, very pliable, and soft. But in the proximal part, who had the sufferance, there was this little scar. However, all the finger was covered, so the balance of the flap, I think we can consider it a quite good results. Last case that I show you is a male of 45 years old with a work-related trauma to the second, third, and fourth digits of his dominant hand. So it's a multi-digital involvement. He had a fingertip loss of all 3 digits with noble structures exposed, so flexor tendon and neurovascular bundle. But everything is functional, so flexor tendon and the IP joint are functional. So the patient arrived with these 2 parts. Not so good, but there is a little artery, and the other part we use the third fingertip like a graft, and the second we reimplanted it with microsurgical classic technique. And at the end, for the third finger, we decided to do something that it's not so much invasive for the patient, because also for the other 2 finger we were not sure of the results, so we decided to do the minimum for this patient. So we take the venous free flap. In this case, the pattern was the binary pattern, and the dimension was quite long but narrow, and we were able to do most of the wish list. So we made it retrograde. We closed the shunt, which was only the terminal part of the artery and the vein. It was not possible to include other vessels because it was narrow, and we had artery and vein by the same side. So at the end, This is the immediately postoperative results. And at 6 months, it was a pretty nice, it had a pretty nice results with a good function. So I finished the clinical cases for today.
I am very surprised because after some weeks, the aesthetic improved a lot. So after some weeks, so here it's perfect.
Yeah.
Yeah. Another thing that for me it's important, because after doing that, so I could see that in the first days, so it's quite normal that the flap suffers a little bit, no? It seems that it suffers a little bit.
Yes, you never you should accept for the first week, but also for the first 10 days. Then the flap has a little bit of a swallow,
Yeah.
but I think it's normal, because at the end of all the cases that we performed in front of a situation like this one, which was, I think, the more clear swollen here, in front of situation of these, at the end we have a good result.
Yeah.
So
are you doing something special in these cases, like bleeding or something, or not?
in these cases we try to use bleeding in the I think in the third day, but we remove it because the patient was bleeding a lot. So probably was really bleeding a lot, the patient. So we never put the bleeding, and the healing was natural without other resources. I use heparin in prophylaxis for thromboembolism prophylaxis and cardioaspirin, and we stopped to use cardioaspirin in this patient for the bleeding.
Are you using heparin or not?
Yes, but in prophylaxis.
Okay.
So not in anticoagulant therapy.
Yeah. For how many days?
For about 2 weeks.
Okay. And corticoids or something like that, or nothing more?
Yes. We use corticoid so we start with 8 milligram, 8, 10 milligram, it depends, and then every day we make 2 milligram less.
Nice. So could you say that nowadays is your gold standard for this kind of defects or not?
I don't know if it's the gold standard. I think that
For you, in your algorithm.
For me, I think that I have a good feeling with this flap, and also I consider this flap a gold standard in patients who don't want to risk enough to have other type of flap, like I don't know, heterodigital flap. I don't believe in heterodigital flap because you're aggressive to a digit who is normal, not injured. So I prefer to do this flap, for example. This is my little.
And if I can add something, it's a very good option in emergency, because it's easy to perform at the same time of emergency. You don't need to prepare the food. You don't need to prepare anything. You can do the same flap, the same operator without 2 equipes or 2 teams. You don't need nothing special to realize this kind of flap. And the two a little bit failure that we are due to a not so good pre-operative plan. This is really important. If you plan very well, your flap is predictable. The result is quite predictable.
And on the donor side, I could see that you are closing directly.
Yeah.
This is also,
yeah.
This is also something that it's very positive.
Mm.
Yeah, a friend of mine, Thomas Giesen, published a very large flap that probably need to use another system to close. It's not possible to close primarily, but in the major part of this case is probably to close primarily, because you design in oblique shape on the palmar side of the forearm. It's quite easy to close primarily.
Yeah, I think that is very interesting, very interesting. And also these tips and tricks, now I could understand better, because sometimes I am trying to read some papers, but it's true that you could see the draws, but it's difficult to understand it. And now I think that it's easier. Okay, some questions in the audience? Congratulations, because you have 15 cases?
Yeah. 14.
14. Congrats. Okay, so they don't have questions. I have a lot of questions, but yeah, I enjoy it a lot. I like it. I like it. When I choose my first case, I will send you.
Yeah, of course. We're waiting for, huh?
Yeah, it's true that I love pulp, but it's true that for some cases, as you can say, for example, for traumatic or for these emergency cases, I think that this is for sure that it's over heterodigital or modigital, these kind of flaps. So and this is funnest also. So it's funny to perform micro. So here you have a question. So could you see the chat?
Yeah. There is not a special way to choose the arterial. It's the vein. It's important to have the vein that match very well in the same direction of your artery. Is a question of draw. Is a question of geometry of the flap. Only like this, and it's important to avoid to perform the anastomosis close to the shunt. This is very important, or close to the valves. This is important. But for the other thing,
this is about the design of the flap, so you can choose it.
Yeah.
Yeah, and even if you want, you could choose. You could have longer pedicle because you are doing with very short pedicle. But if you wanted, you could have longer pedicle.
Yeah.
I like it. Thank you.
Thank you too.
Thank you too.
Okay, so thank you very much, and yeah, thank you, thank you. I'm happy with this presentation because at the end I learned a lot. So yeah, I think that I'm going to use it.
Okay.
Thank you, Sergi.
Have a nice afternoon.
Good afternoon. Bye bye.
Bye.
Thank you.
Thank you.
Thank
Bye.
you very much. Bye bye.